Welcome everyone to this island of certainty in the very uncertain times that we're in. It is now my pleasure to introduce our speaker for this afternoon, someone who does not need any introduction, certainly in the province of Ontario, and that is Helen Angus. We learned, like many of you, that Helen was stepping down from her role as Deputy Minister of Health in the near future. And some of us were surprised because we thought Helen had more time to serve on her sentence. But obviously, it's been reduced owing to good behavior. And so, Helen, we're glad to see you here. We can't think of a better person to talk to the ever-moving agenda of health transformation. You have possibly the most difficult job in healthcare in Ontario. You've got by far the largest budget. You've got a complex, demanding sector with an insatiable appetite. You've got COVID. You've got the health transformation agenda. And you've got, dare I say, a very political portfolio to deal with, let alone the actual business of running our health system. You've all seen Helen's resume, and from her unique vantage point, she has influenced and certainly led innovations in Ontario. So we could not let all this experience and wisdom escape us. And so Helen has agreed through this event to share her vision, where we are, what remains to be done, and how management and leadership in healthcare must change to reflect changing needs. So before turning the session over to Helen, there are just a few things I'd like to mention. I'd ask you, if you haven't already, to close your mics and video screens. And if you have questions, and we hope you do, to direct those questions to the Q&A function on your screen. And once Helen has presented, I will direct your questions to her as moderator. So with that, Helen, welcome. And thank you so much for participating in this particular event. Please. I think you're muted, Helen.
I just say thank you very much, George. It's a pleasure to be here. I'm just looking at that picture thinking, yeah, it is time for a haircut. It's been a heck of 18 months, and I've been in the job over 3 years, and it's certainly been a privilege. And it's really nice to have a chance to reflect a little bit. You know, we've been so busy doing and responding to the pandemic that the idea of taking a pause to think about what we would talk about here today, has been really helpful to me. So appreciate it very much. And I do hope that we do have a chance for some questions. So I'm going to talk about the journey of health system transformation, where we've been, how COVID-19 steered us on and off course, I think is the lesson here. I think there are some remarkable examples of leadership and change that probably would not have been possible without the backdrop of a major crisis or challenge in the healthcare system that unlocked some collaborative behaviors to solve problems that I think we've been trying to get to for some time. And then finally, some thoughts about the path forward. And I've added some personal reflections about what I think is coming. So, and I guess, if I was to put the bottom line up front, transformation is hard. And there are lots of factors that I think really aim to preserve the status quo, or the way that the pie has been divided up in healthcare for some time. I would say that innovation, and it's part of the topic today, has been and will continue to be key to transformation, whether it's process improvement, technology, um, using data and analytics differently, artificial intelligence. But it's hard to scale up for systems level impact. And Ontario is sort of notoriously challenged, where we have wonderful innovations and certainly having done some work in the space where people go offshore and struggle to get a foothold, and they become wildly successful, but struggle to get a foothold in the healthcare ecosystem in Ontario. But I think what we've seen during the pandemic is that some of the barriers for change can be overcome, and so I'm optimistic um, that with strong kind of will, strong leadership, and a rationale to do things differently, that in fact that transformation is possible. And you're going to hear me being, I guess, quite optimistic about the capabilities that we've assembled, for example, at Ontario Health, and how those have made a material difference to the speed and nimbleness of the pandemic response. Working with a ministry that I think really wants them to be incredibly successful. So maybe we'll go to the next slide and certainly talk a little bit about the journey. Maybe the next one after that. There we go. So the Ministry of Health has been on a transformation journey for a number of years, and in fact, back in 2012, when I was happily at Cancer Care Ontario, I was recruited back to the Ministry of Health to become the ADM or the Associate Deputy of Transformation. And it was in that period of time that we designed and implemented something called Health Links, which I think were very much the precursor and maybe a less evolved version of Ontario Health Teams. But certainly tried to adopt and scale up, technology, expand options for healthcare, break down some programmatic silos, both within the ministry and then the field. And so, every government, regardless of political stripe, has had health transformation, as an explicit goal, and they may have kind of approached it somewhat differently. But I think, they probably have more in common in some ways than differences. So if I go back to sort of the beginning of my mandate here at the Ministry of Health, the major sort of structural transformation of healthcare started really in earnest in the summer of 2018, where we were trying to look at what we, how we could target more funding to frontline healthcare, how we could improve overall system efficiency, how we could improve the patient experience and access to integrated care, and how all of this could work in a more integrated way, both operationally around patients, but also at the systems level. And there was an awful lot of streamlining that was sort of, I guess, in the forefront of our initial work of provincial programs. I actually came into the ministry at the time. There were 23 assistant deputy ministers, which might not, sound like a lot when I think at the time we were $55 billion budget. But it did break up the healthcare budget into such small units that it was actually hard to get things done without getting a lot of people into the room together. And that challenged both decision making inside government and as well as the sort of interface between government and the people who actually work in the healthcare system and are trying to deliver care and get clarity of vision and funding and everything else. And the challenge, I think, at the time were, in the transformation we wanted to address, and you see here on this slide, system costs, and no surprise, we've been hearing about these for an awful long time, about the drivers of healthcare and trying to manage costs in the system. And over the previous few years, we had understood the complexity of high cost patients with complex needs, and how the system, really didn't wasn't organized is probably the best way to put it, to really meet the complexity of needs of the high cost users. And that, you'll recall, for those of you who are old enough, was some of the foundational work that was done on HealthLinks. Stakeholders had long been calling for a health system capacity plan that would really take a longer term view of what actually needed to be put into place in order to meet the increasing demands and complexity of the healthcare needs of the population of the province. And we saw the sort of wait times and alternative level of care, bed use as kind of, I guess, the symptoms of not having the right capacity in the right place and the right mix of services and the right volumes. And certainly the government this government came into power with a very strong mandate and messages around ending hallway healthcare. And again, that's really a symptom of not having a properly resourced and articulated and implemented capacity plan. And then finally, I think, there's a patient orientation around fragmentation and trying to improve how patients and families navigate the system. And, we learned again a little bit about that in the work on HealthLinks when we sort of started to parse out the kind of patient journey that Ontarians often experience, particularly the most complex, where they had, sometimes 16 different physicians, lots of different medication and medication interactions, and sometimes all the activity in the healthcare system was more a function of not getting what you needed than what you needed, and at its worst, there were patients and individuals who would be in the emergency department almost every day of the year, and really there were probably other better solutions for them than obviously ED care. And some of that was not even healthcare, it was housing and other things. We also learned that, over the last decade, that, digital tools hadn't kept pace with how, many people want to receive their care and interact with their care team. And so, that was an area of, I think, frustration, where Ontario was lagging behind other jurisdictions, and where we could see improvement being made. So, I've talked a little bit about, the ALC problem was a big one. About 15.5% of all hospital inpatient days going into this transformation were alternative level of care, patients waiting to go elsewhere. Other jurisdictions like the UK were at about 5%. And every time the Commonwealth Fund produced their annual report on primary care, I must say my heart would sink. They have a sort of an American concept of a medical home, but their ability to show how other jurisdictions were much better at getting patients were able to see their primary care provider same or next day than they could in Ontario was always a personal disappointment to me. I happen to be married to a family doctor, and so I sort of point of pride wanted to see the primary care numbers be better than they are. And so maybe we'll go to the next slide. There we go. So just talk a little bit about what the elements were of transformation. And I think some of them have really stood us in very good stead through the pandemic, which again, is sort of, as I'm on the precipice of leaving my post, give me some comfort that we were in the right space. Now they will have been reshaped somewhat by our pandemic response, but I think the elements were pretty significant and pretty kind of spot on. So if I think about what was, ending hallway healthcare, again, that's really trying to, again, dealing with the symptom of the lack of capacity. And certainly Dr. Ruben Devlin and the Premier's Council on Improving Healthcare and Ending Hallway Medicine made a number of, I think, important recommendations about integration, innovation, efficiency, better alignment, how to enhance capacity. And I would say that we were making pretty good progress on the recommendations to end hallway healthcare and some traction in on the ground before COVID-19 came and swooped into the province in January of 2020. And some of that work ended up being very helpful as we had to plan for, kind of a rapid increase in hospital capacity, some of which we used, some of which we didn't use. And we were able to kind of build on that in order to add, new acute and critical care beds, looking at what we call alternative health facilities, but really kind of subacute, post-surgical care, rehab care, and as well as other innovation solutions to load balance across the system. And that sounds pretty technical, but during the pandemic response, particularly in wave 3, we had to move an awful lot of patients across the province in order to sort of optimize their care and give them the best access to ICU capacity, given that the COVID was quite unevenly distributed geographically. And even at the tail end of wave 3, we were actually able to take on 53 patients from Manitoba. And that was really as a result of how we were really starting to dig into capacity just before the pandemic hit. I would say the next one is the Ontario Health Agency, and I spent 10 years at Cancer Care Ontario, and so certainly was a challenge to, I guess, explain and build out the support for amalgamating multiple provincial agencies into a single agency, Ontario Health. And so now we have sort of multiple organizations. We have one organization that uses the same kinds of tools, but in different clinical areas to oversee, the quality of healthcare delivery, to improve clinical performance, to provide support to providers and better quality care. And that's proven to be a remarkable asset during the pandemic. And I'll talk a little bit about that later, but this was a big structural change. Those are always disruptive in a transformation process. Sometimes it takes quite a while for that disruption to settle down and for the true value to be visible and realized. And in this case, we moved, 5 provincial health agencies: Cancer Care Ontario, Health Quality Ontario, eHealth Ontario, the back office for the home care program, the Health Shared Services Ontario, Health Force Ontario, the marketing and recruitment agency that helped with the recruitment and retention of health professionals. And we also integrated the LHINs into sort of 5 interim geographic clusters. And then finally, in April of 2020, we actually moved the Ontario Telemedicine Network into Ontario Health as well. So now we have 6 agencies inside Ontario Health, and Matt Anderson, who's a terrific leader and has been my partner throughout the pandemic response, is now kind of getting some breathing room in order to really kind of figure out, how to optimize all of these different capabilities inside a single organization. And he's put, Chris Simpson, for example, who some of you may know, into a key role in terms of the sort of the clinical lead for the whole enterprise. And they've been able to sort of act as one and help us on the deployment on the ground. And we've got some wonderful examples of that, whether it's building out a lab network over the last a few months that actually can move volumes of COVID tests around pretty seamlessly, networking public health labs and hospitals with phenomenal turnaround times, and going from less than 5,000 tests per day to a peak capacity, which we're not using at the moment, but a peak capacity of about 120,000 tests a day. So it's really again, you can see the application of their ability to have a provincial view, and then the relationships that they have with all the providers, and sort of speed to implementation has been really a hallmark of what the agency has been able to do. And I look forward to seeing in the coming kind of months and years what they're able to do in other important areas. And we've asked them to do, work in genetics, and obviously in their core programs of cancer. I'll talk a little bit about the Center of Excellence in Mental Health has been established under their leadership. So, they've got a pretty good, I wouldn't say recipe is not quite the right word, but again, a systematic approach to quality improvement that could move across, I guess, problems or sectors within the healthcare system. On digital health, again, it was starting this transformation journey. We were sort of sitting as a laggard in internationally, where we had 1 to 2% of visits happening virtually each year, and where we thought, that we were going to be on an upward trajectory, and we're going to have to use all kinds of levers in order to really move a digital agenda forward that would be meaningful for patients. And now I think we're seeing in some parts of the healthcare system, and the primary care as an example, we're seeing about 50% of care is being delivered virtually. And so that really, would have been beyond a stretch target for us at the beginning of this, as I said, at the beginning of the transformation journey. And so as I look forward, I think, how are we going to sustain this and end up with the right balance between in-person and digital care? And how are we going to increase the ability of Ontario Health Teams and all their component parts to offer patients not only virtual care, but online appointment bookings, access to their own records and everything else. And I think we've shown that we could pivot really quickly. The introduction of the K codes, which allowed physicians to bill OHIP kind of one-for-one virtual as they would for in-person, has really made a difference. And the other thing that I think is important that we've done during the course of the pandemic is also leverage the power of data and digital capabilities for research as well. And I'm hoping that will become a greater lever for innovation. So for those of you who know Jane Philpott, who's now the Dean of Medicine at Queen's, she's been chairing a group on the Ontario Health Data Platform, which is a kind of secure, high-performance computing environment for large linked health data sets that both use, traditional analytic methods, but also machine learning. And so again, I kind of look at that. That's a platform for the future. Right now, it's really designed to link the data that is part of the COVID response. And so eventually, again, this is my hypothesis here, is that will become a platform for the province to use for, healthcare research, and we can, become a leading jurisdiction, I think, as we are, but also in looking at health analytics, understanding population health, and really using our data systematically and to its best advantage. I've already talked a little bit about Ontario Health Teams. And so this is kind of the ground game. There's parts of this about the infrastructure at the province. Ontario Health Teams are really the ground game of transformation, and it's where local healthcare providers are empowered to work together as one coordinated team, no matter how they provide care. And it's an idea that, again, born out of some of the experience of HealthLinks, but really aim to help improve navigation, improve the transitions in care for patients between things like hospital, home care, primary care, long-term care. And at the end of, once they're mature, Ontario Health Teams will be responsible for delivering like a full coordinated continuum of care for a defined patient population. I think we have about 80 in formation right now. And same, there was a hunger in the healthcare system to work together and collaborate. And I would say, you know, I was remain delighted by the uptake of the Ontario Health Team idea in communities. There wasn't a lot of money on the table. Intrinsic motivation is just, you can't buy that, right? The idea that people got into this business of delivering healthcare because they care about their fellow human beings and because they want to help address healthcare population health needs. And when you give the people who work in the system an opportunity to do that in a structure to do that better, it is remarkable how people actually step up to work imaginatively around a population of patients. And some of them are really moving along very nicely, and others are still in the queue, and people are still lining up and doing the work, even in a kind of stretched environment of a pandemic. And I would again say that the elements of the Ontario Health Team, I actually got my second shot of for the vaccine by a team that was working at my local Y, and they were branded as the Mid-Toronto West Ontario Health Team. And I think that the Ontario Health Team idea, this collaboration, ended up being hugely important in the how providers came together to respond to the pandemic, whether it was collaborating around IPAC resources, whether it was about redeploying staff to healthcare environments like long-term care that were particularly challenged by the pandemic, and whether it was the vaccine rollout and working together as a team. So this is one thing that I'm really heartened by, and I think there's some really interesting lessons about how you can approach a pandemic by working with the aspirations of the people who work in the sector. The next area is mental health and addictions, and that's obviously been an area of, well, it's complex. It probably hasn't had the same attention that some of the areas of need, of health need, have had over the course, certainly, of my career. Sort of started with a federal government commitment to support provincial governments in implementing more comprehensive mental health and addiction services in their jurisdictions. Certainly, we've heard same kinds of issues that we've heard with Ontario Health Teams: wait times too long, how to navigate to get help, fragmentation. And so, part of this has to be, how does mental health and addictions kind of fit within Ontario Health Teams? And I think that's work that probably still has yet to be done. And again, we kind of put, in addition to the ministry team, we kind of put the A team on it from the Ontario Health Agency and asked them specifically to set up a center of excellence, building on the experience of Cancer Care Ontario, whether it was in cancer or renal, to see whether they could really accelerate improvements in mental health and addictions. And we've been able to respond again to the pandemic using the Center of Excellence, using the reach of Ontario Health to get programs, up and running quickly. I think this is going to be an ongoing area of focus. It's not clear to me, what the mental health and addictions issues are going to be in terms of scope, scale, and severity coming out of the pandemic, but certainly the early indications are that this is an area that we're going to have to pay even more attention to as people sort of get out from under hunkering down and get back to life and realize that it's taken a bigger toll. And so having this infrastructure there may be a little different than having all the funding, but certainly having emergency funds and the infrastructure and the reach and the locus of accountability for mental health, I think is something that is differentiating from the previous efforts of transformation. Home and community care, similarly, like, you can't touch one part of the system without touching another. And so certainly home and community care has been a focus. It's an area of growth in the healthcare system. Certainly, my personal observations is, we kind of fund it on a particular way that has not necessarily and govern um, uh, home care in a way that really doesn't support innovative integrated delivery models. And so the intention has been to introduce, as we have done, the Connecting People to Home and Community Care Act that basically lays out sort of the complementary work to the Ontario health legislation and try to set the preconditions uh, for delivering home care in a different way. And so there's a lot of kind of machinery in motion where the LHINs have been sort of now are basically home care organizations. They've been consolidated under a new home and community care support service organization. So as I look forward, I think we've done some of the heavy lifting on the structural side. The challenge over the next couple of years will be to really bring some imagination to the home and community care sector to make sure that it has the leadership necessary to be a fully mature part of the healthcare system. And as I think about this, when I look at some of the modeling that's been done on the gap in healthcare services that has occurred as a result of the pandemic, we're actually going to have to crank up surgeries, for example, not in every area. We've done most of the cancer surgeries, good, a vast majority of the cardiac surgeries, but things like eyes and hips and knees and other things have lagged behind that. There's a lot of home care that has to be delivered in order to keep up with the system running at 115, between 110 and 120% of usual care in order to be able to deal with this gap. And so that's going to require a fair bit of, imaginative thinking and probably some innovative funding models, including bundled payments and other things that we've used in the past, but probably not to fullest advantage. So as I look forward, I think those are the kinds of things that we'll need to implement. On supply chain, that's been a really interesting one for me. So the government had aspirations before the pandemic to use the sort of the bulk purchasing power of the broader public sector to really buy as one and to stimulate better pricing, better sourcing of products and in particular that are needed not only in healthcare but in education and other sectors. And if you kind of buy as one, you are going to get better prices, and then you can aggregate demand in order to stimulate domestic production. And that's exactly what's happened, and that's why we're manufacturing N95s, for example, in Brockville at a kind of refurbished 3M plant. And so that will more than meet our domestic needs. And we certainly found that in the early days of COVID, probably nothing kept me up more at night than the worry about whether we would have sufficient PPE and other critical supplies. It was really sort of April of 2020, April 2021, and May 2020, sorry, where we looked at the fragmented nature of the supply chain really was evident. And we had people chasing down PPE and on planes in China. The plane is on the tarmac in Shanghai. And then we had people coming to us who claim to have PPE who may or may not have had it. And it was a rush to secure enough PPE. And while our stockpiles both federally and provincially may not have been what they should have been, even at sort of increased levels, it would not have been sufficient to deal with the challenges in the supply chain. So this is another sort of permanent feature. It is a support to the health system. It's not necessarily health system transformation, but it will affect how health organizations buy PPE and other supplies, and hopefully deliver value and be a stimulant for innovation if we do it properly. And we have some really interesting examples where we did a bunch of one-offs, and some of you may or may not be familiar with some work that the ministry did was to try and look at implantable cardiac devices and see that we were able to kind of get down to like 4 models by consulting with clinicians, patients, families, and others, and thereby save, I think it was almost $100 million over a 5-year period, just by reducing some of the, the multiple providers of cardiac devices that were sort of marginally different from each other. And it turned out, not surprisingly, that when you listen to patients, the thing that they were most interested in, of course, was durability, right? They didn't want to have to go back through a surgery and everything else. So, it's trying to sort of triangulate the needs of patients in the supply chain as well. So lots more to come on this one, but I think it has great potential to really be impactful on how we buy and how we innovate, and the prices that we pay, and link how we buy to some economic development opportunities in Ontario. And then finally, public health modernization. And I would just say, we started the pandemic having done a bit of a look at the public health units, of which there are 34, and thought, if to be fully prepared, and we didn't know there was a pandemic around the corner, but to deal with the full mandate of what public health units do, which is quite substantial, right? They have disease prevention, infectious diseases, population health, environmental issues. There's a pretty deep set of accountabilities in the 34 public health units. And of course, most of them are nested in municipalities, and they are varying shapes and sizes and capabilities. And so the modernization was really intended, less as a structural reform and more, how do we make sure that public health units actually have all the capabilities that they need? And, do a little crosswalk over here into the digital first for health. And, do they have the advanced analytics and epidemiological capabilities that they need in order to truly understand their population? And then how would they actually help and interact, not be integrated with, but work with primary care and Ontario health teams in order to advance the health of the population? That was put on hold, obviously, because the public health units are really the frontline response to the pandemic. And, on that one, I think, once the pandemic is largely subsided, I think that there is a need to do some real stock taking, and what have we learned from the pandemic experience, and recast what we would want to do on public health modernization. There was a similar review done at the time of SARS, I guess not quite 20 years ago, which led to the creation of Public Health Ontario, for example. But that stock taking really needs to happen, and with a new I guess a new chief medical officer of health from Kingston, who, I think also has sort of ambitions to really, bolster the public health response, so that we are prepared in case this ever happens again, and happens again in less than a century. So I'll go on to the next slide, and I'm just looking at the time. I want to make sure we have time for questions. So yeah, I'll wrap up fairly quickly. So quadruple aim, I'm sure most of you are familiar with that. So that's what we're hoping to achieve with all this, and certainly trying to also up our game in measuring and making sure that the things that we do actually achieve those outcomes. So go to the next slide. There we go. Impact of the pandemic. We'll go to the next one. Thank you. you know, it's still, the pandemic is still playing out. We are very much preparing in case there's a fourth wave, but also working to try and get our vaccination rates up as high as we can. I think today we crossed the 19 million vaccine threshold. And so, you know, basically we ran it on two tracks. And I think I've talked a little bit about how the things that we were working on as part of the transformation really played out in the pandemic response. But it was pretty fast and furious, long hours, and you know, many hands to actually kind of work on, you know, trying to flatten the curve, and deal with the challenges that we had on the public health side. And so we built, for example, in a very quick order, a case and contact management system that allowed, you know, test, trace, and isolate, allowed public health units to really up their game on case and contact management, but also allowed us to have a reserve workforce at Public Health Ontario that could supplement any local area that was being challenged, and that has happened and endures to this day. The implementation of public health measures, obviously those have been tightened and relaxed, and has been you know, embedded in legislative vehicles. The testing system, I think I've already talked about the labs, but to ramp up over, I think it's about 150 assessment centers, largely in hospitals, but not entirely, expanding the lab capacity by using hospital community labs as well as public health labs, and to ramp up specifically when we saw the devastation in long-term care homes in the early part of the pandemic, to put into place an incident management system that would really coordinate the response and provide additional IPAC support and other resources. And so, you know, I think those are the things that it shows me that we can move quickly when you're absolutely required to. I guess for some, maybe not quick enough, but again, it's some remarkable ramp up of capability, the building of IT systems, training, deployment, use of those, and very much flying the plane while it was in the air. And then similarly on the capacity side, I think I've talked a little bit about really building out a whole new procurement system for PPE. We added 2,500 new beds at the height of wave one to the hospital system in order to prepare for what we thought might turn out to be a situation. We were looking at Italy absolutely being devastated by COVID. And again, that sort of had the foundation, the work on ending hallway healthcare. We had to use the Emergency Management and Civil Protection Act to allow healthcare workers to move between health facilities, whether that was, you know, hospitals, long-term care, home care, and public health. And I think we did that in a way that was responsible, because that's quite a sweeping authority, but it sort of showed, you know, how health human resources and the people who work in the healthcare system could actually be flexibly work in a variety of different settings wherever the patients needed them the most. And we implemented new billing codes for virtual care, and so it was really kind of all hands on deck across the system. Go to the next slide. Yeah, so the guiding principles, I think one of the things that I want to call out here are some of the enduring principles. So we obviously wanted to build on the transformation initiatives because that's where we already had some traction. So again, the immediacy of the response was able to leverage that. I think I've made that point several times. action-oriented, bias towards action. You know, there's a lot of people that will have a, you know, a lot of analysis. We try to be very careful, you know, in the public service about how we advise government. We really had to have a bias for action and push through ambiguity and uncertainty. I would say it became pretty obvious pretty quickly that COVID was experienced differentially, both geographically and the disproportionate impact on high-risk communities. And so our response had to leverage, you know, data. We had to collect information. We had to cut it differently in order to understand the deciles of the population and how they were impacted by COVID, whether they were getting tested, whether they were able to isolate. We put into place all kinds of community supports, community transportation services, isolation, hotels, and other things. And I guess if I look forward, I really hope that this focus on equity, having really built out that capability, is an enduring part of the healthcare system. And then we've got, you know, the provincial response structure, best practices, and IMS. I'm sure we'll parse that out over time as well and get some lessons learned from that. The engagement with healthcare partners, it was a lesson for me, certainly from the beginning, where, you know, the health table was originally called the health command table. I thought I had to be a commander, but actually it had to be a better partner. And so it was really important that we had, you know, daily calls with health sector organizations and leaders, separate calls with their communicators, a collaboration table. Everything, you know, was done in partnership, including our good partners at OH and Public Health Ontario and the public health units. And we were criticized for having an unwieldy response structure, but I think actually that collaboration and those locuses of partnership, whether it was a primary care table, a table that was dealing with home care, those were our strength. And then finally, groups on data, science data and evidence, and trying to really inform decision making. And I think the modeling table particularly was a big part of trying to see around corners and where we were going. Because we had never done this before, we certainly had to use the modeling. So how do we go to the next slide? I think I'll leave some of these slides with you because I do want to get it. There's sort of the waves. And so you can sort of see how the pandemic response really had to shape it. You know, we had to be nimble and change the shape of the response and use different vehicles over time. Go to the next one. So this was the fall pandemic plan from last fall. And you can see again how we were trying to balance out, you know, the pandemic response. What we worried about but didn't happen was an influenza year as well on top of COVID, and we would have a hard time differentiating those. And at that time, we thought, we didn't know we were heading into a wave 2 or wave 3, you know, dealing with service backlogs, preparing for routine needs. And clearly we knew then, as we still know now, that one of the biggest challenges facing us is health human resources. And that's an area that's going to require a whole lot of attention. Keep going. Next slide. So, you know, what we've added since then was we used, you know, there were hundreds of movements. Some of them were two-steppers too, to move patients across the ICU sorry, back one slide. We talked a bit about that. The vaccines came faster than we thought. And so we had to, again, turn to the sector, hospitals, public health units, primary care, pharmacy to really participate, which again is sort of reinforcing of the whole OHD approach. We had to figure out how to use rapid antigen tests, so rapidly deploy a new innovation into the healthcare and the workforce environment. A lot of attention to patient flow, different ways of deploying human resources, fast training for staff. And again, I think I've mentioned some of the features of the high priority community strategy, which I hope stick around. So keep going. So here's where we are today. I think this is pretty darn current, so you can see we are at 79.7% of the population vaccinated, of the population over 12 vaccinated. We'd like to get higher than that. We're slowing down a bit. As you can see, the curve is flattening both for the first doses and now for the second doses. 66, so 2/3 now have their second doses. We're a leading jurisdiction in vaccine deployment, and I would put that again at the feet of the task force that's overseeing it, but again, also the collaboration on the ground that's actually implementing. I think at peak, we were doing about 270,000 vaccines a day, which is a remarkable number. So let's just go to the last slide, I think. Oh, there's one of our equity charts. I talked about the deciles. So again, that sort of shows you the kinds of analysis that we have done, and we will be doing more of this as we go forward. Next. There we go. All right. Well, I just think I'll give you some personal reflections. So I'd say that, you know, the healthcare system has risen to the challenge, and then some during the pandemic. And we saw some terrific examples of collaboration, some of which I've tried to highlight. We had to ramp down planned services in favor of treating COVID patients and move to virtual care in a way that I don't think we ever could have imagined. The healthcare gap is largely modeled at this time. And so it's going to unfold as people start to show up in their primary care practices and then get referrals to specialists, and we'll see, you know, how big it is. There are some worrying signs there. I think, you know, the percentage of PAP tests done in the last year compared to usual is unfortunately quite low. And so we don't know how big it is yet, and we don't know the impacts of the lockdowns on mental health. Things that we don't understand yet are the healthcare needs of long haulers. So that's an area that we need some more science on. And I think it's going to take months, if not years, to dig out from the impact of the pandemic. And so, you know, the challenge for us will be not to go back to the same, but to go back to something that's different, and realize that our starting point for transformation is in a different place than it was at the beginning of the pandemic. And so, as I've said many times here, that you know, the work of the Ontario Health teams has proven itself during the pandemic, and so I remain optimistic that the energy of the collaboration will take us to new places on overall health transformation. I do think we'll need to sort out what the optimal amount of nature virtual care will deliver the best health outcomes. Is 50% the right number? I don't know. And so we'll have to be keeping an eye on that. There certainly is a very tired health workforce. And certainly we have anecdotes that suggest that people are leaving the sector in order to recharge. And, you know, I expect that we'll have to start to be more imaginative about how we think about the health workforce going forward. I think we're going to have to be more nimble in addressing the capacity challenges. I do worry about austerity. You know, the governments of federally and provincially have taken on very large debt in order to fund the pandemic response. And so I think that's going to raise some interesting policy choices for governments, and perhaps impact some other not inexpensive reforms like pharmacare and other expansions of the social safety net that some governments have had on their docket for some time. And then, as we've just looked at, the pandemic has laid bare health disparities, and certainly those cannot be unseen. My hope is that those continue. So with that, I will close off and look forward to your own observations or any questions that you have. So thank you for your time.
Thanks so much, Helen. Very well done. It just made me realize not only the complexity of the agenda, but the amount of progress that you have made on so many files. And it all, of course, has to be coordinated, and it's interrelated in so many ways. One of the areas, and we're seeing it on some of the questions, and I would encourage people to please put your Q&A, your questions on the Q&A function so that we can direct these to Helen. But one of the areas you've mentioned now several times is the health human resource area. And that seems to be a focal point of concern with our audience, is just where is this going? I was listening to a CBC program the other day, and I assume they had reliable data. They were talking about a 25% vacancy rate in RNs and RPNs in Manitoba. And I've had more friends come to me and say, I just lost my primary care physician and I don't know where to turn. The physician is sort of retiring early or whatever. But there seems to be a growing concern on the primary care front about the availability of primary care. And I'm just wondering if you could comment on this in more of these short-term dimensions as we, embark on this, what could I call it, the pre-post-COVID era?
Yeah.
Can you be a little more specific, perhaps, on where you see government going in particular around this agenda?
Yeah, I think obviously, if there are things that we can do to keep the workforce, even in a modified way, and healthcare providers supported to stay in the workforce, I think we need to do that. And I know my team, David Lamb and Michael Hilmer, have been, working really hard. I think we were able to find people to come to support the pandemic response. And we set up a matching portal and all kinds of things. But many of them, many people came out of retirement because it was a calling to, basically support Ontarians, in a time really of war, right? War against a virus. And so when I look forward, I think we're going to have to implement different kinds of training programs, different kinds of support programs. We're going to have to work with the regulatory colleges to introduce some, I think some flexibility. We're going to have to look, internationally as well. I spent a little stint in my career as the Fairness Commissioner, but about access to professions and trades in Canada. And I think that because of the lag time it takes to train a professional. But now there's some accelerator programs that have been put into place. There's some practice changes that have been put into place, but I'm not sure that those deal with the fundamental physics about whether we have enough people actually to do the work in healthcare. There's wage issues that are going to have to be addressed, and I think there's probably a different look offshore, and we've admitted, I mean, it's remarkably few foreign trained physicians each year actually kind of get through the process and are able to work, and nurses similarly. And I think we are going to have to kind of fire on all cylinders. My hope is that we can provide, enough flexibility and support to give the workforce a break and not lose them permanently. But it is something that the team is working on, a more formal strategy, because it was the rate limiting step, I think, in wave 3. And if we had crested much higher than we did, we were at the edge of our capabilities, I think, in ICU, for example, and other parts of the response. I'm interested that in primary care. I'll be interested to see how much of it is I need a break and I'm thinking about it versus I'm actually putting in the paperwork. I'm going to draw down the pension because I understand that there may be a gap between the two, but that doesn't mean we don't have to work as hard as we can to fill those spots. But it's a tough one, right? know if anybody here has any better ideas, but it's a tough one. Takes, you know, how many years to train a nurse and then, you know, have them ready to perform in the ICU, the operating theater, or other things. It's got a long lag time.
We have a sort of an addendum to this whole area question. Contributing to the growth training of HHR, Health Human Resources, can you talk about how the different ministries collaborate and coordinate?
Yeah, it's interesting. I think, you know, our deepest collaboration is with the Ministry of Colleges and Universities. And, you know, during the pandemic, we spent quite a bit of time working with them, but I think we actually probably need to do a whole recast of the health workforce plan after the pandemic, and that's one of the things that's going to have to be done with MCU. And we did put into place very rapid training programs with them for PSWs. You know, for PSWs and RPNs, you know, it's not just, they work not only in the health sector, right? Or, you know, in the Ministry of Health sector. They work in long-term care. Some of them work in developmental services. So we've got you know, there's lots of competition for resources. And certainly the PSW challenge is one where, you know, there's quite a wage differential between the various sectors that employ PSWs. And the one that keeps me up at night is home care, because of the, you know, the numbers of visits that use every year, or that they do every day, and the wage differential between home care workers and those who are workers in PSWs. And of course, after the inquiry on long-term care, you know, there's going to be a great focus, rightly, on the HHR and long-term care, but we need to balance that, of course, with HHR elsewhere. So I think it's ripe for a real review about all the things that we're doing, and are they sufficient to get us to where we need to get to.
Thank you, Helen. We have a question here taking a bit of a different direction. The questioner thanks you for a very informative presentation. How do you see the transformation from reliance on institutional care to more community care? And what is a realistic timeline?
Yeah, I mean, that's always been the objective of every government, is to look at the optimal balance between institutional care and community care, whether it's home care, but it could be supportive housing, it could be community mental health programs and other things. So, you know, we've been on the journey, and certainly the investments in the community side until the pandemic were much larger than the institutional side. That being said, the institutional side certainly commands an awful lot of attention. I think the Premier was actually in Ottawa today, and I know he was hanging out with Cameron Love. I think there was a capital announcement. And so, you know, those big institutions, you know, they have been workhorses. The pandemic showed that they could partner, and they had sort of enough deep capacity, it probably didn't feel like that on the ground, to be able to run assessment centers and vaccine programs and COVID response all at once. So I think that's been interesting. But it's not the policy goal of governments to you know, run everything through institutions, and run things more through, you know, community responses. I think Ontario health teams should help on that rebalancing, but this is a multi-year journey, right? That we've kind of been on, but it probably hasn't changed the power relationships necessarily in the health sector.
We did have a question, and unfortunately right now I don't have my my chat function, but it was a question on innovation. And It's more or less how can you ensure that innovation and health policy are integrated so that the policy function follows the innovation and supports it in a meaningful way. And I suppose we spend a lot of time looking at new technologies and new ways of doing things and so on. But how innovative are we in how we implement these things? You know, the policies, the way that we facilitate the implementation side. The innovation seems to be very much on the product or service outcome. Is it as innovative, or is innovation built into policy and practice as much as you would like to see?
That's a good, interesting question. Yeah, I think, you know, in the ministry, so the policy and the research area are in the same place. And so much of the evidence synthesis and evidence development function, although everybody paid attention to the science table, was actually a ministry led function. And they do, you know, briefs and other things, not only on the products, but also on the response. And I would say what had been helpful was, for example, the Munk School sent senior public servants, including myself, kind of an international view of the COVID response weekly. So who was doing what was happening in Austria, what was happening. And so again, the time and the reach of organizations and universities to actually maybe do a little bit more thinking about how to implement a response to a pandemic, for example, has been enormously helpful. We often look to, that's been criticized, but we look to some of the larger consultancies who have international reach, for example, to bring to us, you know, how similar problems have been addressed in other jurisdictions. You know, so, you know, we do try to have an outward focus on problem solving, and I think that's public service at its best, is when it's able to bring that and sort of kick the tires of some orthodoxies about how we do things around here. I would say, you know, can we benefit from more air in the room? Absolutely. And I would say that, you know, having a, you know, a strong Ontario health organization that really had its finger on the pulse of what was going on, because they had many, many tables during the response, meant that I could go to OH and really get a read on how things were landing and whether we needed to alter our implementation approaches because they weren't achieving the intended impact, or they had unintended impacts that we just couldn't contemplate or hadn't thought about at the beginning. And that the partnerships were important. The partnerships that they had, that we had as a result of their relationships, I think made us better. Should that continue post-pandemic? Absolutely. And then trying to bring some implementation science to the work as well has been a challenge, because you know, public servants, we're pretty good process people, right? And so trying to get us to focus on outcomes and bringing imagination and, you know, to a very complex set of problems certainly, you know, had its moments. So yeah, I guess my short answer is, yeah, we can do better. Do we have the asset in Ontario to be able to do better? Yes. Do we use them systematically? Probably not as much as we should.
Okay, I have a question here. If you had a magic wand that gave you the ability to change one decision you made as deputy minister, what would it be?
other than a human resource decision. Let's see. Well, I wish I had dragged out the pandemic, the influenza plan earlier in my tenure. And I think what I've learned is to probably spend more time thinking about risk. And I think the whole government needs to spend more time, and probably all organizations need to spend more time thinking about risk and risk mitigation. And, you know, we had practiced, not during my tenure, but, you know, emergency preparedness and responses to things like Pan Am Games that were events. You know, they were 3-day events. Although I think we've done very well as a jurisdiction internationally, you know, it would have been better, like, I guess it's a sin of omission. It would have been better to have spent more time thinking about risks and thinking about what would an enduring pandemic actually look like, because this is completely different than SARS. That probably would be one of the top of my list of if I could buy some time back, that's what I would do. I always felt 2 weeks behind. I always felt like, you know, you're catching up to a pandemic that's moving, that you can't really understand the shape and nobody's ever, at least, you know, in our lifetime, have responded to something quite like this before. And I always thought, if I had just if I just knew, you know, if I knew this 2 weeks earlier, that it was going to move into this environment, or that we were going to, you know, the vaccine was going to arrive in December instead of April, you know, everything might have been just a little smoother. That's hindsight.
So we have a question here as we are likely going into a federal election, what role or could or should the federal government play to address the health workforce issues you raised?
Well, send money. Help us. I think, I mean, international recruitment is not the answer, but it could be part of the answer in the short term. I think there are probably some, I don't know whether there's opportunities for standardization across jurisdictions. Invest in training programs. I think those are the kinds of things that we would be looking for. It probably would not be helpful for the federal government to, you know, come in and take over post-secondary education as a, you know, that just kind of sets up a jurisdictional problem that I don't think is necessarily an improvement. So they need to support the provinces in the areas that they're accountable for, and help bring best practices. And maybe there's a summit or something. I'd be certainly interested in spending more time with my colleagues about the things that work, that they found have helped, because there's no doubt in my mind that if Ontario is facing challenges, so is probably Quebec and Alberta and BC and Manitoba and everybody else. So we're all on this this journey together, and if there's anything we can do in the collective, that would be helpful.
Okay, we do have, this will be, I would assume, our second last question anyway. We can agree to the general statement that the implementation of Ontario Health has been largely about increasing efficiency of Ontario's healthcare system and improving the quality and consistency in care that patients receive across regions, i.e. by consolidating agencies. When you consider the large number of OHTs, oh, I just lost the question. See if I can pull it up here. Yeah. How can we help ensure that local decision makers are enabled to make decisions that reflect the needs of their populations while maintaining a high degree of efficiency.
Yeah. I think that's kind of the challenge, right? It's the tension between standardization and local customization. And I think the thing to do is focus on outcomes rather than on processes and inputs, and be tolerant that there's going to be, somewhat different configurations and maybe different processes, and maybe even different locuses of leadership, but that they actually are trying to produce some standardization in outcomes. We haven't really seen, OH has been pretty focused on the pandemic and keeping the lights on the programs that they operate. So I don't think we've seen the full set of possibilities that OH brings to Ontario Health Team implementation. And I think that's something that I know Matt is pretty eager to get to. And again, it's about the same journey as what we had in cancer, I think, and renal, which my experience would be, let's try and focus on some key things that we're trying to achieve, whether it's the timeliness of care, the quality of care, and certainly on patient outcomes, and maybe be a little more permissive on the how. And as I've said that, I think Kevin Smith has said to me many times, as CEO of UHN, Helen, just tell us what you want to achieve, and then we'll tell you how. And I think the OHT should be a permissive structure rather than one that is, overly dictated on the processes that they use to get to the result. And then, I've always said with these kinds of things, if there's if one set of configurations achieves a better set of outcomes, then at some point, then maybe you do standardize a little bit more. You have a menu of approaches that have been shown to work, as opposed to the later ones having to do this completely greenfield. But I don't think we know yet exactly what the optimal size, scope, scale, governance of an OHT is going to be. So I hope that we all keep an open mind until we start to see what the real results are for patients and what are the things that actually produce those results.
So a final question to you, Helen. This is a university event sponsored by Telfair School, and we have a lot of young, aspiring, emerging leaders in our audience. What are the competencies, capabilities that you see most important moving forward in our leadership and management? Sometimes we forget that one of our health human resources are our health leaders and managers.
Of course.
And so what thoughts can you share with us on that?
Yeah, I mean, I look at sort of the young staff here and what's a differentiator, and I think being authentic. So you have to be yourself. You can't kind of put on a personality to come to work. You have to be an authentic, engaged leader. You have to enable your teams. You have to be able to imagine a different future. And I think, again, there's a bias for action and optimism that comes with leadership that is important. That there's a better place, and that the people will want to follow your direction and see you as a source of wise counsel, and that you're bringing them with you in a flexible way, because they're going to learn from your own staff as well. When I think about the skills that we need, and I'm talking a bit closer to home, but it's probably the same in other organizations, is kind of change management. There's lots of people who can tell you what the right thing to do is, or what an agenda for change would be, but how do you bring a group of people, some of whom are highly motivated to follow and want to build it, but some of whom are not? How do you actually do you have a toolkit of change management to actually implement a transformation, whether it's in a unit or whether it's a level of the health system. I think those are important things to have. And nobody does this alone. And so one of the things is, are you a good collaborator? Can you work with others? Are you a good team? First and foremost, are you a good team member? Because I might be the leader of the Ministry of Health. I'm a team member with, a co-lead with Matt Anderson and the Chief Medical Officer of Health of the COVID response. And I'm a team member with of the Secretary of the Cabinet, who's now Michelle D'Emanuel, with all the other deputies, of which there are like another 26 of us. So, you've got to play different roles. And I think you've got to, at the end of the day, it's, how do you collaborate to solve complex problems by working with others and being able to do it kind of happily. And then the other thing is pay attention to your own resiliency. If I've watched my team, who are also like the people who work in the healthcare system, although different jobs, different role, they're also tired, and some were better able to pay attention to I need to take a half day off and just pay attention to my own mental health, or I'm feeling short-tempered, and so I got to sleep in for a couple of hours extra so I won't be at the morning meeting. And being able to be resilient, I think, is also a differentiator for a long career. And self-care is, I think, is pretty important ingredient in that.